Okay, I think we'll try to start. Audrey, is that everybody? Yeah. Okay. So, welcome back. I hope you enjoyed your well-balanced nutritional lunch with observing the pyramid and light on bread and heavy on other things and so on. So look, welcome back. Before we formally start, I want to another initiative that OvaCare are doing is that we are I suppose we're hoping to launch this as it's a diary for patients suffering from ovarian cancer. What we want to do though is we've about maybe 10 of them that we got at this kind of pre-production stage, and we'd like to get people who would take them, look at them, review them and give us their feedback on them before we actually go to final print. And we really would like if you would do that, right? Because to produce them are expensive and we want to get them right. Okay, so we've about 10, Audrey, is it? 8. Okay, we've 8, and look, we've stamped just envelopes to send them back to us and so on. So what we would love to do is, if you would be so kind as to take one of them, review it in your own time, take a couple of weeks to look through it because it's a mighty tome of work, right? But we would value the feedback, and then just send it back to us, and we'll go and get them printed and so on. So, and if any volunteers, go and nab Audrey before you finish up. Okay. Our first speaker this afternoon is Professor Seamus O'Reilly, and he's going to speak on the 10 questions asked from patients with ovarian cancer. Professor O'Reilly is medical oncologist at Cork Mercy and South Infirmary Victoria Hospitals since 2001. He's an active member of the All-Ireland Cooperative Oncology Research Group, where he co-chairs the Gastrointestinal Oncology Disease Specific Group. He's a member of the board of Cork Cancer Research Centre. He's also chairperson of Cork Arc Cancer Support House and co-founder of the Southeastern Cancer Foundation. And he's also a very good supporter of these events and a very good supporter of OvaCare, and we're delighted to have him here. So, Professor O'Reilly, we welcome you.
Thank you.
Okay.
Thanks very much. I'd like to thank June and Sharon for asking me to speak. When I asked Sharon what I was supposed to talk about, she said that they'd received 10 questions. An email was sent with questions. So the questions received were this: chemotherapy schedules, blood vessel targeting, immune system after chemotherapy, surgical menopause, immunotherapy, and ovarian cancer in younger women. And so each of these has a number. There's 1 to 10, and the slides will have the numbers addressing them. So I've tried to, in the talk, to go through each of these and address them as we go through. So ovarian cancer is a worldwide disease, and this is from the International Association for Research in Cancer, and it's a website called Globacam. And what you do is you go online and you can put in there are various You can put in the disease type, ovary, and what the statistics are, and whether it's worldwide or in Europe. And you can see it's predominantly disease of the developing world, of the developed world, less so of the developing world. So the darker the colour, the more prevalent it is. And we have similar cancer atlases for Ireland, and this is the ovarian cancer atlas for Ireland. And you can see there's a huge predominance in our region. It's rather dramatic, isn't it?
Yeah. But I'm from Dublin and I moved down here 12 years ago.
You increased our figures. So this is also webbable from the National Cancer Research, from the Cancer Registry in Cork. And colon cancer is similar to this. It has a larger uptake in the southeast and southwest. And melanoma is also similar as well. So if you look at the melanoma map of Ireland, it goes purple all along the south coast. It's like a belt, a melanoma belt that goes right along here. And it's much less further up. And it's so it's very interesting why that is the case, or why it should be that way. We think melanoma is probably more prevalent because there's more sun. I'm from Galway, the sun never shines in Galway. And so we don't get those kind of things, but in the southeast it does, the sunny southeast. It's more difficult to figure out why it is for other things. if we look at the age distribution of ovarian cancer, in Ireland, 20% of people will be under 50, 20% would be in their 50s, 20% in their 60s, 20% in their 70s, and 10% around will be over 80. So it's a disease that really affects women at probably one of the most productive times of their lives, at the times when they're involved in raising families, similar to breast cancer in that regard. Ovarian cancer starts in the ovary, but also starts in the fallopian tube as well. And I think that's important. So people who have preventative surgery for ovarian cancer need the tube removed and not just the ovary, because we think that the fibres at the end of the tube is where many of the cells develop, and they spill out into the ovarian cavity or they spill out onto the surface. Particularly with the hereditary forms of ovarian cancer, that it's very important to have for the tubes to be removed as well in the surgeries. And when it divides out, the ovary starts as a high-grade pathway or a low-grade pathway. So with the low-grade pathway, these are tumours of what we call low malignant potential. So they develop like cancer, but they don't respond to chemotherapy, and they're treated mainly with surgery. They're less common, but they tend to affect younger women. The higher-grade tumours tend to be sensitive to chemotherapy, and they will be much more common. Ovarian cancer is not one cancer, it's a family of cancers. So this is ovarian cancer by the type of tumour it is. So there's what we call a germ cell tumour, which is similar to testicular cancer. They tend to occur in younger women. I would say 1 in 10 of the women I see with ovarian cancer have a germ cell, or maybe less, have a germ cell tumour. The majority of the other ones have the more epithelial subtypes, so papillary serous is very common. And there are less common ones like the low-grade tumours and the endometrioid cancers. And the outcome varies depending on the type. So green tends to have a better outcome, and red tends to have a more difficult outcome. The red ones tend to be more responsive to chemotherapy than the greener ones. The slower growing tumours don't tend to respond as well to chemotherapy. So when we think about chemotherapy, we think about chemotherapy given by vein, which is the most common way, but it can also be given in other ways as well. So if we take the average patient presenting with ovarian cancer, the most important thing in our care is surgery, because surgery reduces the cancer, and the outcome, depending on how much cancer can be removed, is important. So if you look at the survival figures for women with ovarian cancer, the people in the blue, with the blue line, have microscopic disease left behind after surgery. So everything is removed so that they can't see anything at all. And then smaller tumours between 0.1 and 1 centimetre are left behind. That's the yellow line. And where the tumour is more than a centimetre in size is the grey line. And you can see that the benefits of surgery apply for up to 5 years after diagnosis. So there's a significant increment in that. In some women, they're too unwell to get surgery first. The tumour is rapidly developing. They've been sick as a result of it. We tend to give chemo first and then follow surgery. Many other women, we do surgery first, followed by chemotherapy. It doesn't seem to matter whether you've had chemo first and then surgery, or surgery first and have chemotherapy. The studies show similar outcomes. And often it's a judgment call in the unit at the time about who's on first. What type of chemotherapy you get is determined by clinical trials. So this is the largest ovarian cancer trial, about 4,000 women, and in it they looked at Taxol and carboplatin compared to a variety of other treatment options. And the study showed that Taxol and carboplatin was as good as any of the other ones. We use the other ones sometimes because people might have allergic reactions to one of the two drugs. They may not be able to get them. They may have neurological problems, which makes giving Taxol very difficult. And what this study shows us is we can do things in a variety of different ways which are equally effective. The outcome is the same, and we tailor it to the patients involved. It has often been highlighted that the ovarian cancer tends to stay in the tummy cavity for quite some time before it spreads to other areas, and giving chemo into the tummy area would make a lot of sense. So this is called intraperitoneal chemotherapy, and a tube is put into the stomach similar to a dialysis catheter for people on peritoneal dialysis, and chemotherapy is administered through that. It's very effective where the tumour nodules are small, because if the tumour nodules are large, the chemotherapy can't get into the area. It only gets in by 1 millimetre or 2. So if you've got a 2 centimetre tumour, it's not going to penetrate adequately. The advantage of this is concentration. So if you look at here, this is pharmacokinetics, where we measured the drug concentration. So this is where someone's getting chemo intravenously versus into the peritoneal cavity, and they measure the concentration of the drug in the fluid in the tummy. So you can see if you give it by vein, the concentration is much less than if you give it by into the tummy. And we, in our job, we tend to think that the higher the concentration of drug you can get near the tumour, the better the more effective chemotherapy is. So this has been developed in some centres. It's technically quite difficult. Several studies have shown a benefit with it, but there are side effects too in terms of infection, in terms of bowel toxicity. So while it's taken off in some centres, it hasn't been universally endorsed everywhere. There's a learning curve with it, and I suspect we should probably be using it more than we are. And I think that it probably has a role in a selected group of patients. These advances in treatment have led to improvements in outcomes. So if we look at thanks very much, from 1975 on, you can see significant improvement in survival, the average survival of patients with ovarian cancer over time. And it's sequential. It's a bit like if you look at the Volkswagen Golf, Mark 1 versus Mark 9. There are little changes between them, but they all look kind of the same between a Mark 8 and a Mark 9. But if you take a Mark 9 versus a Mark 1, it's a transformative thing. And it's the same with cancer medicine. It's a little change each time. So it doesn't seem like you've made a lot of progress if you just look back for a year, but if you look back for a decade or 2 decades, you've made enormous progress. One of the big progresses in cancer medicine for ovarian cancer is this role of blood vessel targeting. So we think that when cancers develop, they switch on the blood vessels and then they grow. And this, without the philosophy then is if you get rid of, if you stop the blood vessels forming, the cancer can't grow, so it will shrink. So drugs targeting blood vessels have been developed for ovarian cancer, and this is the most important trial called the ICON trial. And in it what they did was they gave standard chemotherapy after surgery or chemotherapy with Avastin. They gave Avastin for 15 months. And what you can see here is after 15 months, the curve kind of drops off as the cancer returns. So the feeling is that maybe if you didn't stop at 15 months and continued it for longer, that you might have a better outcome. And there's an improvement in survival in some patients with it, what we call high-risk patients. So patients where there's very bulky disease or they have bulky disease at presentation. So we've used this more frequently in patients now at an earlier stage in diagnosis. So when people finish that initial primary treatment, there's 2 possibilities here. They go into remission where the cancer goes and it never comes back. And we've patients with very advanced disease where we're very concerned with them at presentation where it's 5 years out and nothing has happened and they remain well. And there are other patients then where the cancer comes back or where it doesn't clear fully after the first treatment and they remain with disease. And then what you're looking at is what we call survivorship from here of people living with cancer or living after cancer. And there's a lot of interest in this survivorship as more and more patients develop cancer and survive from it. There are 25,000 breast cancer survivors in Ireland. That's the population of Galway when I was growing up. There are 100,000 cancer survivors, and that will grow year on year. And when we see people in follow-up, there's a lot of debate about what to do. We used to do this blood test, the CA125, every 3 months, initially and every 6 months. But a large English study found that didn't make a difference in terms of outcome, and patients became very fixated on the marker and what it was, and suddenly found the quality of life was consumed was dictated by a blood test rather than by anything else. So based on this study, we don't tend to measure this after initial diagnosis now, unless there's other factors involved. Say if someone's on treatment. And we don't want to continue it if it's not working, or if someone is at risk of a bowel obstruction, if the cancer progresses, then we tend to measure it. The marker varies between people, so you have people where the marker is like 1,000 or 20,000, and others where they have similar disease amount and the marker is only 500. So why is that? Well, the cancer doesn't make the marker, your body makes the marker. So when the cancer is there, it irritates the lining of the stomach or the lining of the lung, and this protein is released by that and goes into the bloodstream, and that's what triggers it. So the marker is found elevated normally in women before the menopause because it will change with their cycle. So as your cycle goes on, you get follicles appearing and then disappearing and breaking, irritating the peritoneum, so the marker goes up and fluctuates. It also goes up if you have a blood clot involving your lung. It will go up if you've fluid within the tummy cavity for other reasons. So it's not specific for ovarian cancer, and it doesn't correlate with the bulk of disease. It's really helpful in terms of determining response to treatment. So it's fantastic from that point of view, where you can judge quickly if what you're doing is working or not. When the marker comes up, the tumour has returned, and we're looking at a situation where the cancer has come back. And what we want to do when we're seeing people in the clinic, when the cancer comes back, we want to pick them up when they're well, not when they're too unwell to get more treatment. And this is often a clinical call. Much of the time when we see people back in the clinic when the cancer comes back, they know them. You may do a scan, but patients know themselves, I find, that something is not right. They don't feel right themselves. And I think that we would, this is, for those of you with glasses, it's fuck it, I'm going home. And he really looks pissed off, doesn't he? So anyway, I think that professionally, when cancer comes back, I feel it's much worse than when cancer is diagnosed. When cancer is diagnosed, there can be hope. And there's always the prospect that this is a bad chapter in the life that's just going to close and move on. And whereas when cancer comes back, it's more that you're looking at more of a life of living with cancer. I think that there's often from a doctor's point of view, there's often a feeling of therapeutic failure. That could you have done better? But I would also say that while we would say fuck it, I'm going home, the patient can't go home because the patient can go home, but they've got to live with the circumstance. So that's a more difficult thing. So I don't want to make it sound that this is all about doctors feeling badly. I think it's a huge problem. I think it's a much more difficult chapter for patients. When we get into this scenario, then we're looking at sequential chemotherapy of time on and off chemotherapy. Now, with some of the newer drugs, the blood vessel targeting drugs, we may start that drug and then continue it if it's effective in terms of the cancer. There's a kind of a feeling that it sensitizes the cancer cells, or it makes the chemotherapy more effective, that the benefit of chemotherapy lasts for longer by continuing it. And this is a recent study called looking at giving bevacizumab with chemotherapy in patients, and you can see that it's more effective. Yellow get bevacizumab and blue don't. That it keeps the cancer away for longer, but it doesn't improve survival. The survival curve is similar between the patients. What they've also found with this is that it mightn't improve outcome in terms of long term, but that symptoms are better. So people have better symptom control if they get Avastin, because the treatment works quicker and the cancer stays away for longer. And that often in someone who's living with cancer is worthwhile. Doesn't make a difference if you're treated really intensively if you've got ovarian cancer when you've come back. Well, that's been looked at too. So this is a study from America. Gynecologists give chemo there and comparing medical oncology with gynecology. So if you were treated by a gynecologic oncologist, you stayed out of hospital for longer, you had less chemotherapy, fewer side effects from chemotherapy, better quality of life. No difference in outcome. So all women know this, that the faster you drive doesn't mean you'll get there quicker. And men don't. But I think that it is a salutary lesson that more horsepower isn't always more speed and isn't always better outcomes for patients. Now, with all of this, there are patients who can do incredibly. And I was in my office one day, and it went ping, and it was from a patient sent this. His brother sent it to him, and he said, "No pressure, Seamus, have a read." So this is the patient who forgot to die. So this man was diagnosed with cancer in the United States in the 1960s. He had survived the Second World War and emigrated to America from Greece. And things looked bleak, and so he went back to Greece to go home to die. He went home to die and lived on an island in Greece, and this was taken a few weeks in 2012. And so but he didn't die, so he went back to America then to talk to the doctors who looked after him to find out what was wrong, had they misdiagnosed, etc. But they were all dead, and so he had no answers. And but there are some people with. So what could have happened is his immune system could have switched on, and that might have gotten rid of the cancer. It could have been a wrong diagnosis. Spontaneous remissions do happen sometimes, but there are people who do considerably better than we expect. And I have a patient who had metastatic cancer metastatic breast cancer involving lung, biopsy proven in 2001 when I started here, and she had chemotherapy for 6 months, and she was last seen by me earlier this year, alive and well. Her cancer's gone completely, and she's had a dramatic response. So there are instances where we see dramatic results with treatment, and I think part of cancer medicine and research is to find out what happened there. Because what happened there, if we could recapitulate what happened there elsewhere, then we would have very successful treatment. And so a lot of cancer research is to find out why people do dramatically well with treatment and why people don't do well. And this is coming out next year. This is a book, The Emperor of Maladies. It's about the development of cancer medicine, and written by an American oncologist. And this is the website for it. They're making a documentary which will come out next year. And it's a really very readable book. And when we see people who do well, one of the triggers that we look at is why we look at people who do well. But the other thing we look at is cancer developing in families to get clues about what might cause cancer, because if you can find out what caused cancer, then you might be able to target it. So this is a family with ovarian cancer and colon cancer. It's called the Lynch syndrome by Henry Lynch, an association of colon cancer, cancer of the womb, cancer of the ovary, and cancer. We see cancer of the kidney and cancer of the breast in some of these patients. And by studying these patients, we get an insight into what causes cancer and also into how we can target it better. So if we take ovarian cancer, about 10% of patients have hereditary disease. So we see the BRCA mutation, BRCA mutation, is in some of our families in Cork, and it's not rare, but it's not uncommon. And there are other syndromes like the Lynch syndrome and the Li-Fraumeni syndrome, which are associated with ovarian cancer. But in a lot of patients, we would also say that there might be hereditary, that you see cancer in generations, breast and ovarian cancer, and the gene tests are negative and we're not sure. So there's a group out there where we've identified the genes, but there's another group beyond that where we're very concerned that there's a gene present, but we haven't identified it yet. So looking for these genes is important because it gives us targets to treat. And this is Ehrlich, who developed antibiotic therapy. It was a father of what we call targeted therapy, and won the Nobel Prize in 1908. And he was the father of targeted treatment, looking at where you have a protein on the cell and you get a drug to target it and kill the cell. And these targeted therapies make a huge difference. This is a drug, rituximab, developed for lymphoma in 1995. And this is from Canada, looking at the outcome of people with lymphoma before this drug and after this drug, and you can see a dramatic difference. So this is an example where targeted therapy has transformed a disease. And looking at these genes, when we look at these genes here for personalizing therapy, the BRCA genes are up here. They're very high penetrance, so if you have these genes, there's an 80% chance of developing breast or ovarian cancer, but they're relatively rare. What we're looking at now with newer technologies is genes that might be more common in the population, but harder to find, because these would identify these other families that we're concerned about, where we feel that there's a gene present, we just can't locate it. And this is how this is being done. It's called the Cancer Genome Atlas, where they're taking a variety of cancers and they're doing sequencing on them, taking 1,000 patients with each of these tumours. So ovarian cancer is listed here, and they're looking then at maps of signalling within the cell to look at ways of getting drugs to target them. And this is what it looks like, the results, looking at a third of patients have changes in this pathway, and you can see that the BRCA changes are also present as well, and the people who have BRCA mutations do better than the people who don't. So these complex pathways are ways in which new targets and new drugs will be developed. And some of these are coming to fruition now. And part of this is where each of these of different subtypes will have different changes associated with them. So you can see BRCA mutations are associated with these papillary serous tumours. That was one of the questions that was mentioned earlier. In breast cancer, they've looked at genetic assessment in people in the clinic. So they've gone into the clinic. So people attending a clinic in Boston, they've done genetic sequencing on their tumours. And what they found is that in 85% of patients, they've been able to find a target that they can get a drug for. So in the future, I think this will be happening, where you won't just get the pathology report saying papillary serous tumour, endometrial tumour. You'll be getting a readout saying what are the targets that we can identify for treatment. And this is called personalised medicine, where the treatment is personalised to the patient and not just to the type of cancer they have, but also a more detailed analysis of it. There's an enormous amount of work being done in clinical trials. This is a map of clinical trial activity globally earlier this week on a website. And you can see in Europe there are 10,000 clinical trials in patients with cancer. And in ovarian cancer there's 500 trials. And we're involved with ICORG, the All-Ireland Cooperative Oncology Group, which is bringing clinical trials to Ireland. About 2,000 patients are enrolled in cancer clinical trials in Ireland every year. And this is the ovarian cancer trial that's ongoing at the moment for newly diagnosed patients, called the ICON trial. It's part of a larger group of European and Canadian investigators looking for newly diagnosed patients to find the optimum chemotherapy for them. In all of this venture, they're also looking at different other targets for cancer. So this is the Hallmarks of Cancer in 2000. This looks difficult, but it's not. Think of it as Anglo-Irish Bank, okay? So if we think of the cancer, it's self-sufficient to growth signals. In other words, it can stimulate itself to develop. It's insensitive to anti-growth signals, so the regulator, it doesn't listen to the regulator. The regulator wasn't speaking, so that didn't help. It can spread. It went to America. It is limitless replicative potential. You know, we would be paying for it forever. And it's sustained angiogenesis, so ability to bring things around it. So it's not just the cancer cell on its own that we're talking about. We're talking about the environment around it and these different targets that we can look at. So these are the targeted therapies looking at endothelial cell, which is the blood vessel, where we target the blood vessel and the tumour cell. So it's not just looking at the cancer cell alone, but also beginning to look at the environment around it. And so in ovarian cancer, the developments then, so bevacizumab in ovarian cancer is the use of blood vessel targeting agents, and these Parp inhibitors are also coming to the fore as well. So I just want to talk about them for a minute. So the Parp inhibitors target genetic instability in the cell. How does this work? So patients with the BRCA mutation, if you think of a chair has 4 legs. So in a patient with a BRCA mutation, the chair has 3 legs. And that makes the chair vulnerable, because you can sit on a chair with 3 legs, but you can't sit on a chair with 2 legs. And what happens is that when cancer occurs, you eliminate the 3rd leg, so the thing becomes unstable and a cancer develops. But equally, if you therapeutically target the 3rd leg with a drug like a Parp inhibitor, you also kill, instead of the cancer cell growing, you kill it. And as a consequence, the cancer, those cancers with that specific change, that BRCA change, because they've got 3 legs instead of 4, are going to be sensitive to those drugs. So the Parp inhibitors are given by vein or by mouth, and this is one of them called olaparib, and it's developed by AstraZeneca, and we expect it to be coming to market probably next year. And this is relevant to women who have a familial form of ovarian cancer, but also in some women with these high-grade papillary tumours, a significant proportion of them have this genetic abnormality that makes them sensitive. So they don't have the hereditary form, but the cancer carries that abnormality, and that makes them very sensitive to chemotherapy and will be sensitive to these drugs. So these are given orally at home. You can see a dramatic difference between the people who did get it and the people who didn't get it. So this is a wonderful new development based on our better understanding of ovarian cancer. The other one that's happening is immunotherapy. So one of the big questions in cancer medicine is why the immune system doesn't recognize the cancer. And that's because there's a protein that's blocked here that switches it off, so that the immune system here in green recognizes the cancer as abnormal, but there's a blockage system here that prevents it pulling the trigger. The newer drugs then target this and break this bind so that the trigger can be pulled. So these are called immunotherapies targeting this drug, program DEath 1. And in melanoma, where we think of a lot of immunotherapy being active, you can see this is a patient CT scan of a patient with melanoma with lung mets, and you can see that they go away with this immunotherapy. And this is a patient with lung cancer, which we think is not sensitive to immunotherapy at all, but we were wrong. And you can see liver involvement here, there's liver shadowing here on the scan, here and here, and that's gone away with treatment with this immunotherapy. So these are drugs that are coming to the clinic now. We're using them for melanoma, and we hopefully will be using them for lung cancer, and I suspect for other cancer types like breast, like ovarian cancer. when I was doing this talk, I came across this, and I was going to, it was an undeletable thing. It's called the Dryathon for charities. I thought it was brilliant. Oh, the official rules: no alcohol from 12 o'clock on January the 1st, so they're allowing people to celebrate, and from 9 a.m. on the 1st of January until the end of January, and to raise cash for Cancer Research UK. I thought it was superb. Definitely a plagiarisable idea. So I think the other important thing I'd like to stress is that there's more to oncology than chemotherapy. So this was a unique sunny day in Galway. It poured rain about 2 hours after I took this photograph, so just in case you thought it might be sunny, but it doesn't last. Anyway, so I think I'd like to talk about other aspects of hope beyond drugs. So one of the most important paper in cancer medicine came out in 2010 was a non-chemotherapy paper. And what they looked at is getting palliative care involved earlier in the management of patients with lung cancer. Normally we get palliative care involved here when chemo doesn't work. What they looked at was getting palliative care involved early on, helping people with their symptoms when they were diagnosed. And then they would get more involved and chemo would get less involved as time went on in the illness. And what they found was that people were less depressed and had better quality of life. You see, the standard care, this is more depression, and if they got palliative care involved earlier, they had better symptom control, but they lived longer, 25% longer in this group. So this isn't a drug. If this was a drug, you'd be delighted. So this is just you reconfiguring existing resources to help patients. And so we try and get this more and more involved now, getting palliative care early involved in patient care rather than late on. We think of cancer now not just as a rogue cell gone wrong, but also as an environment. So there isn't a rogue cell gone wrong won't live. Anglo-Irish would not have survived if there wasn't a political environment to facilitate it, a regulator that was asleep, German banks to lend. So it was the whole infrastructure that allowed that to happen. And similarly, cancer won't develop on its own, it'll die without an environment around to support it. So the newer philosophy of cancer is that it's not just a rogue cell, but it's a rogue system. And I think it's also important to realise that cancer care is not an individual, but it's a system. So this is from Harmony by Anam Cara, and people are looked after by, now it's not just a single doctor looking after you, it's multiple people. And everybody thinks they're the biggest block in the wall of your care. But the important thing about a wall, one of these walls in the Aran Islands, is that the wall will fall apart if you take the small rock out. So while everybody might feel they're the most important person in your care, it actually is all of the people involved in your care working together that will make the biggest outcome to you. The other aspect is prevention. A third of the cancers I see are preventable. Smoking is the biggest issue, and I think spending time talking to people about cigarette smoking when they come to the clinic is important, because they may have lung cancer and may not be able to, and unfortunately it may be too late for them to change, but a significant number of their children smoke, and they represent an opportunity. As a society, we need to spend more on prevention and more emphasis on prevention. James Riley, when he was head of the IMO, said that for every euro spent on prevention would save 20 euros on healthcare costs. The other important thing is advocacy, getting people involved in their care, and this is from the UK Secretary of State for Health. Patients be the heart of everything we do, and so integrating patients more into care. So I think that patients, for instance, should be on the board of management of our hospitals, so that we can hear how we can do better. And in American hospitals, there's integration of patients and family members into the boards of hospitals, so that there can be better communication. And I think the HSE could do a lot in terms of this new hospital trust infrastructure to embed people who are receiving the service into the care, so that we would know how we could do things better. In Germany, they did a study looking at ovarian cancer, and I thought it was very interesting. Most times when we think of what people want with ovarian cancer, we would say better treatment, but that wasn't the case in this German study. Their priorities were more time with healthcare providers, less hair loss with chemotherapy, and better treatments. But better treatments was number 3 in this list. If you ask doctors what patients want, they probably said this would be number 1. These studies have also shown that mental health and physical health are linked. So this is a study in America where they looked at women after breast cancer with sleep disturbance, and they found that in women where they were with sleep disturbance, their cancer came back quicker. They also found that if you look at people with cancer, that if you're non-depressed, mildly depressed or severely depressed, your outcome reduces, so that the mental symptoms are directly related to survival. And that when they treat depression, they look at biological markers and found that they got better. And this is from the editor of New York Review of Books, what he wanted doctors to be able to do. She's a typical physician. My illness is a routine incident in his rounds, while for me it is a crisis of my life. I would feel better if I had a doctor who at least perceived this incongruity. I just wish he would give me his whole mind, once be bonded with me for a brief space, survey my soul as well as my flesh, to get at my illness, for each man is ill in his own way. And in these studies, they've shown that people who have good mental health do better than people who are depressed. So it's very important to address mental illness in this. And this slide is for lung cancer, but it can be produced for a variety of other tumours. Every other tumour that's been looked at has had this. And we often think professionally often think of the impact of illness on the patient, but this book is called A Monster Calls, and you see there are two authors. Siobhan Dowd was a woman with breast cancer, and she died and transferred the book to Patrick Ness to finish. And it describes a child's reaction to the mother having cancer. And this is a yew tree in the garden, which he imagines is the monster called cancer. And the yew tree is the tree that we get Taxol from, which is what the patient was being treated with. But it's a wonderful expose of what a child experiences. I think every healthcare professional should read it. It's very powerful, and but to get insight into what life is like at the other side, and to the impact of cancer on others. The other things that have come out that have been found to be good is exercise. So this is a study looking at people's exercise after colon cancer diagnosis. And the red one is people exercising 3 minutes a week. So what that is sitting at the TV with the remote control. 18 minutes a week is 2.5 hours of exercise a week. But you can see there's a dramatic difference between these groups. And they're doing a study in Canada now where half the patients get no exercise program and half get an exercise program after colon cancer surgery to see if they can replicate these findings. And we think how this works is that exercise stimulates muscles, and there are myokines or proteins released by muscle which regulate the immune system and cell growth. And that has an anti-cancer effect. So things like the dragon boats that are used for the breast cancer survivors, we think there's an awful lot of merit in that for patients who are cancer survivors. So, how can we do better? I think we can in our cancer medicine disciplines divide and diseases unite. So having more disease-specific groups that would focus is important, and that's multidisciplinary care teams have developed in the hospitals, and that's a huge development. We can improve access to care. Access to care is still a major problem for patients, and that's what the medical card issue is all about, I think. Cancer research saves lives. Integrating it with standard practice is very important, so there should be clinical trials units in all of our centres, and we need to do more in cancer prevention. It saves lives, and we need to prioritise it more as a community. Obesity is the next frontier in cancer prevention, but as a society we're not recognising it at all. We're not making it easy for people to eat well. We're not making it easy for families struggling to buy well. And we're not making it easy for people who go to restaurants and that to know what they're eating. And then we need to harness IT and advance in cancer genetics. We need to have better cancer genetics in our country, because I think that there are people at the last meeting I was at, concern was expressed about cancer genetics and the fact that it needs to be more integrated. And we will be concerned as a community that more people need to be tested for cancer genetics as well. The last word. This is cancer survival in the United States, published this month. So the 5-year survival of cancer patients living beyond 5 years, you can see 50% in the 1970s up to 65%. In Ireland, breast cancer survival has gone from 65% here to 80% here. And so the trend is upwards with all of these advances, which is worthwhile. What's good to see here is that it isn't plateauing. It keeps going up, which is what we want to see. So I'd like to thank you for your attention and time.
There was a huge amount of information delivered with great humanity and humour. Yourself an Anglo, there must be a bit of history there because Anglo comes up each time, right?
Anglo makes it's an easy analogy though. I mean, when you the medical students like it.
Yeah. There's pain there. I feel it though. There's pain there. There's definitely pain. So thanks a million for that.